So how do you stage CS cervix? Yes, I told you all cancers of gynae are staged surgically except CS cervix, which is staged clinically. So for the staging, what do? You do a local examination and you do a per speculum examination and you do a per vaginal examination and you do a per rectal examination. This is for the cervical lesions. And remember, the parametrium is best seen by a per rectal examination. See, if you do a PV, you can see the cervical growth and the area around it, the vaginal growth. But for the parametrium, you have to take your finger out and put one finger in the rectum. Then you can see the parametrial growth. All right. Along with that, you must do a cystoscopy for the bladder and then also a proctosigmoidoscopy. So this is the way how you can get to the staging of CS cervix. So what is the staging of CS cervix? So I'm going to write the staging of CS cervix because see, CS cervix, the staging is good 1.5 to 2 pages in your big books. So let's see if I can show you here and try and make some sense of this complicated staging. CS cervix staging is regularly asked in the exams. Now, if you see, the round ligaments are coming here from the top of the uterus, and I told you that the round ligaments go from the internal inguinal canal to the labia in front. Now, the cancer of the cervix has started in the epithelium and you cannot see it most of the times. It is having a microscopic invasion. Then, from the microscopic invasion, how much it is spreading microscopically, that you have to know. So, what is stage 1 of CS cervix? It is limited to the cervix, stage 1, limited to cervix. Stage 1A is the microscopic cancer. 1A1, there is depth of invasion is less than 3 millimeters. 1A2, this depth is 3 to 5 millimeters. Look here, the depth of the cancer cells is very less. It's only around 1 to 2 millimeters and the spread is lesser than 7. I'll write it here. The spread is less than 7. Transverse spread. So, the transverse spread is less than 7 and the depth is less than 3. Now, the depth is almost 5. Now, you think practically. I'll try to show you on my fingers here again. There is a growth which is spreading microscopically just about 3 millimeters and then 3 to 5 millimeters it is in the depth and then it is growing 7 millimeter in the spread. So, if you imagine there is a growth on the cervix which is 7 to 5 millimeters, maybe you cannot see, but if there is a growth which is spreading more than 7 millimeters and it is deeper than 5 millimeters, that is actually let us say 8 by 6 millimeters. So, it becomes a growth which is somewhat as big as this, like this. So, if the growth becomes so big, then you can see it with your naked eyes. A growth which is 8 by 6 millimeters is almost a centimeter size growth, isn't it? So, you can see with your naked eyes. So, if a growth is becoming bigger than this 7 millimeters and deeper than 6 millimeters, it is clinically obvious. So, yes, now we call it a obvious growth. So, stage B, 1B, it's a obvious or a macroscopic cancer. and this microscopic cancer B1 less than 4 centimeter in size, B2 more than 4 centimeters in size. See this? This is a 1 centimeter cancer. Earlier the lengths were in millimeters. If it is more than 7 millimeter and more than 5 millimeter in depth, it is obviously seen. So if it is bigger than that but less than 4 centimeters, it is B1. Now the cancer is bigger than even 4 centimeters. See, it's a 5 centimeter big cancer, but it's still limited to the cervix. So that's why it is a B2. Now, from the cervix, where does the cancer go? It goes to the vagina first. Now let's change the color a little bit and try and understand. I'll change it to orange here. It's the same growth obviously, but I'm using a color code for you to understand. The cancer is now spreading to the upper vagina. So that is what is 2A, upper vagina involved. Now, the cancer has come to the lower 1/3 vagina. It is not 2B, it is 3A, lower 1/3 vaginal involvement. I told you in endometrium, vaginal involvement in CA endometrium and in CA cervix are hot shot questions. So I have given a code of orange. Orange growth here on the top of the vagina is 2A, coming to the lower 1/3 vagina is 3A. Now the cancer has spread to the parametrium. Cancer from the cervix has gone to the parametrium. See, it's gone, the growth has gone to the cervix, it's also involved the area outside the vagina. This is known as the parametrium. So that is now 2B, parametrium involved. But short of pelvic side wall. Now, stage of parametrium in which the cancer is going all the way to the pelvic side wall. I'm just giving you a color code. Obviously, it's the same growth. It's just a color coding so that you can understand better. So, the cancer has gone out from the cervix involving the vagina and also involving the parametrium up till the pelvic side wall. So, stage 3B, parametrium, PM I'm writing, involved till pelvic side wall. Now, there is no cancer free area. There is no cancer free area from the cervix to the pelvic side wall. Now, when there is a cancer which is gone till the pelvic side wall, all of this is a big bunch of cancer tissues, hardened cancer tissues. So, what happens here in stage 3B? The ureter which is coming laterally, which is coming through the parametrium like this and coming in front of the cervix to drain into the bladder, this will get compressed by this growth and will cause a hydronephrosis of the kidney. So, yes, stage 3B is also the stage where you see hydronephrosis. You know what is the most common stage of CA cervix when it presents in India? What is the most common stage of presentation of CA cervix in India is stage 3B, the stage of hydronephrosis and bony cancer. Women in India will be rotting with this cancer, having foul smelling discharge, post-coital bleeding, everything, they'll ignore it. But one fine day when the growth goes and hits the pelvic side wall, bony pain, you know, the pelvic bone is involved, bony pain. She is not going to sit at home, she is going to come to you with that pain. So 3B is the most common stage where you will see CA cervix presenting. Alright, so what is the next? 4A and 4B that are simple. 4A is bladder plus bowel involvement and 4B is distant metastasis. But now the question is, what about Inguinal lymph nodes. Inguinal lymph node involvement in CS cervix. What about that? We have discussed that the lymphatics along the round ligaments, these lymphatics in CA endometrium can go along the round ligaments and come to the inguinal canal, and they can involve the inguinal group of lymph nodes. This lymphatics also from the CA ovary, suppose there is an ovarian cancer, then this lymphatics again can drain into the inguinal lymph nodes. But look at the cervix. Cervix is going to go to the parametrial nodes, to the obturator nodes, internal iliac, external iliac, presacral, rectal. The cervical group of lymph nodes are the ones which are within the pelvis, and cervical lymphatics are not going to go against the gravity and come here. No, cervix does not drain in the inguinal group of lymph nodes. Cervix does not drain in the inguinal group of lymph nodes. So yes, inguinal lymph nodes are not involved in CA cervix. That's the MCQ which has come many times. In CA endometrium, I have told you it is stage 4B. In CA ovary, I have told you it is stage 4B. Now, in CA cervix, I am telling you it is not involved. Okay, that's even your anatomy question. Okay, now some other things about CA cervix. CA cervix, when it is involving the parametrium and coming up to the pelvic side wall, it is the most common stage of presentation. Now, when the cervical cancer spreads to the endometrium, what is the stage? I have told you in CA endometrium, endometrial cancer going from endometrium to the cervix, what is the stage? That is stage 2. Endometrial cancer spreading to the cervix, stage 2. Now, I am asking you, cervical cancer going from the cervix to the endometrium, what is the stage? It does not alter the staging. Yes, endometrial cancer coming to the cervix is stage 2, but cervical cancer going to the endometrium, the stage is not altered. It is considered natural progression of cancer and the staging is not changing. Based on this, there are 2-3 MCQs asked to a few people. Okay? Remember, cervical cancer going to the endometrium does not change the staging. I am being a little repetitive in this topic about CA cervix because CA cervix is one topic which regularly comes in your exams. Okay. Now, we have done the staging, and what is the treatment? From stage 1 to stage 2A, a radical hysterectomy would suffice. And from stage 2B, a chemotherapy and radiotherapy together is best. Chemo, radiation. So, these are the basic punchlines, alright. It is not that this is enough about CA cervix treatment. From stage 1 to 2A, a radical hysterectomy would suffice, and from stage 2 and beyond, chemotherapy and radiotherapy together are going to give the best results. Chemo radiation sometimes is so good for even stage 3B that more than 50% of stage 3B will survive 5 years. Chemotherapy alone is bad, radiation alone is bad. Both these together can be very morbid for the patient, but if the patient tolerates chemoradiation, the survival is really very nice. But yes, what about radiotherapy alone? Radiotherapy alone is effective treatment in all stages of CA cervix. Although these are the basic guidelines of management, radiotherapy alone is so good that nowadays radiotherapists do not let us handle CA cervix. Whenever we have a cancer clinic and we send the CA cervix patients, 90% of the patients are taken away by the radiotherapist. Only a few radical hysterectomies come to our OT nowadays because radiotherapy has got such good results and it is lesser morbid than a radical hysterectomy. Now, when I tell you this, there is a slight modification. I have been telling you the treatment, but there is a slight modification in the staging now, that the stage 2A has been altered a little. Yes, just like stage B has a B1 and B2, stage 2 also has a 2A1 and A2. Yes, stage 2A has a A1 less than 4 centimeters and a A2 more than 4 centimeters. So, yes, stage 2 has now been altered into A1 and A2. So, a lot of people say that if you want to give radical hysterectomy as an option, we can give it to up till stage 2A. Yes, that is what is your answer. But nowadays it is evolving. Maybe it might become a accepted thing at the end of this year. Please be on the lookout. So far I am saying till 2A, do a radical hysterectomy. But yes, who knows, in 2020 you may be told that up till A1 you should do a radical hysterectomy. Beyond that you should do a chemoradiation. Okay, but this modification in the staging has already come. This modification in the staging has already come. Okay. Now, let us see some more important aspects about CS cervix. Let us move on. If I see that CS cervix, I have to give radiation, where would I want to give the maximum radiation? So, there are two radiation points. From the external os 2 centimeters above and 2 centimeters lateral. 2 centimeters above and 2 centimeters lateral to the external os, 2 and 2. This is the point A, and 3 centimeters lateral to the point A is the point B. So, 2 centimeters above and 2 centimeters lateral from the external os is the point A, and 3 centimeters lateral to the point A is the point B. So, what is the point A? A is the place where the ureter crosses the uterine artery. Yes, the ureter crossing the uterine artery is something like this. See, this is the uterine artery giving the blood supply to the uterus like this. But the ureter crosses the uterine artery from laterally. The ureter crosses the uterine artery from laterally and comes under it. So, it is like this. So, yes, the uterine artery is like a bridge over water. This uterine artery is like a bridge over water which is flowing in the ureter, isn't it? So, the ureter is under the uterine artery. Please remember that anatomical relation, it has come many times. And the ureter crosses from lateral to medial under the uterine artery. So, this is the place where you see the parametrium. So, now what is the point B? Point B is the place which is the obturator lymph nodes at the pelvic side wall. So, yes, this point B is the pelvic side wall where you have the obturator group of lymph nodes. Now, you know the obturator group of lymph nodes is also known as the sentinel group of lymph nodes. It is also known as the sentinel group of lymph nodes, the first group of lymph nodes which are involved in CS cervix, and from here the metastasis to other group of lymph nodes happens mostly. So, that is why we say that if the obturator lymph nodes are involved, then the main lymph node which is going to send the metastasis to the other lymph nodes involved, then a radical procedure is warranted. If this is not involved, maybe a localized excision would be enough. So, we can see the involvement of the obturator lymph node by a technetium 99 probe, or we can also use a blue dye and we can find out whether this is involved or not. So, obturator node is the sentinel node. So, why did I tell you these points? Now, these 2 points are the radiotherapy points. I would want to contain the disease by radiotherapy. From the cervix, the cancer will spread to the parametrium, and from the parametrium it will go to the pelvic side wall. So, I would want to bombard the point A with lot of radiation, and this radiation would be in the tune of almost 7,500 to 8,000 rads. But I would also give some radiation to the point B. Now, the point B radiation would be a little lesser, not much lesser, it will be up to 6,000. So, yes, point A and point B, this is what is going to tell us the areas where you should give the radiation to control the spread of the cancer. CS cervix, what is the most common histopathology? So, histopathology, what is the most common cancer cervix? It is the squamous cell carcinoma, large cell keratinizing. That is the most common. It will have the keratin pearls in it, or it can be squamous cell carcinoma, non-keratinizing variety. That is the second most common type, and the third most common type is the small cell variant. The other questions asked is, what is the most common cause of mortality in CS cervix? Yes, this one we know very well, that uremia, most common cause of death in CS cervix is uremia. So, this you know very well. So, they have asked you the second most common cause is the hemorrhage, and third most common cause is the infection. Uremia, hemorrhage, infection. These are the general causes of death in CS cervix. Now, which part of the cervix is involved more commonly in CS cervix than the other? So, the anterior lip is the most common site of beginning of the cancer. Most common site of beginning of the cancer is the anterior lip. And there's a lot of talk about the vaccines of CS cervix. We have the quadrivalent and the bivalent. The quadrivalent is the Gardasil, and the bivalent is the Cervarix. So, Gardasil, of course, both of them will be guarding against 16 and 18. This is also 16 and 18. But Cervarix is only 16 and 18. Gardasil will also have the 6 and the 11 serotypes taken care of. So, Gardasil has more serotypes, but both of these mainly center around the serotype 16 and 18. Now, between you and me, we have already discussed that CS cervix most commonly is because of 16 and most malignant variety is the type 18. But does it happen only because of these two? No, it can also happen because of 31, 32, 33, 34, 40, 44, 47. There are so many other serotypes which can cause CS cervix. So, yes, it will prevent only against this. And if you give these vaccines before the first exposure, then it is 90% sensitive, these vaccines. If you give these vaccines before sexual exposure, after sexual exposure, if you give these, the chance of prevention is as less as 40%. So, that is why the vaccines, to be very frank, if you ask me my opinion, I have to teach you vaccines. I am telling you that Gardasil and Cervarix are the vaccines which are given, but personally I hardly give these vaccines to women, because in India there are so many serotypes and there is so much of CS cervix that even these two serotypes, they keep mutating amongst themselves and they can cause resistance to these vaccines. So, to be very frank, we are not giving too many of these vaccines, but they have come as questions for you. So, I have told you that this is the bivalent vaccine and this is the quadrivalent vaccine, and these are given to women after 9 years of age, and up to 25 is the best time to give. Yes, 9 years girls onwards, up to 25 is the best time to give them, to give protection, because around puberty time a lot of girls get active, and after 21 obviously most of them are active. All right. Thank you.